Bernie, that was fantastic. I wish you'd come and give this talk, because what I'll do is probably really show you that we understand very little about sudden death and hypertrophic cardiomyopathy, but I'm sure Bernie will make some sense of it. So, evidence and uncertainties. In the management of hypertrophic cardiomyopathy, these are the four key elements. Screen first-degree relatives for hypertrophic cardiomyopathy. Avoid competitive sport, volume depletion, isometric exercise. Control symptoms. Assess the risk for and prevent sudden cardiac death. And then in older asymptomatic patients, who we call hypertrophic cardiomyopathy, but they may or may not have the disease. We'll have to see over time with what happens with genetics. But older asymptomatic patients have a very good prognosis, and what we need to do is reassure them, continue to follow them, and make sure we're not missing hypertension, which is untreated. So I'm going to just focus on the left hand here, assess the risk for and prevent sudden cardiac death. Now, the epidemiology of HOCM-related mortality in this study by Barry Marin is shown here, and annual HOCM-related mortality, and what I want you to focus on is the yellow, which is sudden cardiac death, which it tends to be between the age of 5 and 15, the most common cause of death, and then subsequently the rate does go up. But obviously, as you get older, sudden cardiac death as a proportion of total death becomes less. The clinical profile of sudden cardiac death, it's truly sudden, unexpected deaths. Severe class 3 symptoms only in about 29%. The majority of these patients are class 1 and 2. And then, although a great deal is made about sudden cardiac death in athletes, and it may be the commonest cause of sudden cardiac death in athletes, you see that moderate to severe exertion only present in 16%, a significant number in bed, and sedentary mild exertion in the majority. So it really is unexplained. And let me give you excuse me, a couple of case histories. So this is a 47-year-old female who presented with chest pain and hypertrophic cardiomyopathy, no prior history of syncope, and while she was at the Mayo Clinic, we put a Holter monitor on her, and this is her heart rate on a particular day, and it starts off about 80 beats per minute, goes up to about 90, 100, and then in the afternoon, she suddenly gets this significant increase in heart rate, sinus tachycardia, and then this is what happened. In the middle of her evaluation at the Mayo Clinic, she goes into ventricular fibrillation, and is successfully defibrillated. But what is interesting is this rate about half an hour before, a rate of 120, 130 sinus tachycardia. This is another patient, equally unexplained. This is a 24-year-old, and the reason that this patient had a defibrillator placed was his mother had died, had a cardiac arrest at the age of 45, successfully resuscitated. And this was his device interrogation in the middle of the night. He was asleep. This is what happened to him. He was successfully shocked. And what was interesting was this device interrogation was about 2 months after the episode. And I said, "Do you ever recall anything?" No. He was asleep, and then I think he went into a deeper sleep, and then he was defibrillated. This is a very interesting patient, 48-year-old male, who I saw about 2 years ago, came for a second opinion as to whether he had hypertrophic cardiomyopathy. He was asymptomatic. He did have a strong family history of hypertrophic cardiomyopathy, a brother with an ICD of appropriate discharges, a niece with hypertrophic cardiomyopathy, a nephew who died suddenly at the age of 15, and his son had been genotyped and he was positive but phenotype negative. All investigations and examination were normal in this patient, which is why he came for a second opinion, except he had a slightly increased septal thickness, 13 to 14 millimeters, and mildly abnormal strain in the basal septal area. So the issue with this patient was, did he have hypertrophic cardiomyopathy or not? And in the event that he did, he would need a defibrillator because he had a positive family history. Now, about 2% of white athletes and about 5% of black athletes have a septal thickness of greater than 13 millimeters. But he was 48 and not an athlete. And so I said, you do have hypertrophic cardiomyopathy. Your septal thickness is 13 and your posterior wall is 10. That's asymmetric septal hypertrophy. He's asymptomatic. I put in an ICD. ICD implanted. 6 months later, he went into ventricular VT, VF with an appropriate discharge. Never ever had a symptom. This is a lucky patient. He called me and he said, you know, Doc, I think you saved my life. And I said, yeah, yes, I did. So this is the unpredictability of sudden cardiac death in this asymptomatic man. And many people would have said maybe he didn't have HOCM. Now, in this study of 68 patients that we did with an ICD, there were 9 episodes of sustained and 5 patients had sustained monomorphic VT. I hate this mouse. 4 patients had ventricular fibrillation. And what is interesting is the number of episodes. So the VFib patients had 1 episode per patient, but the monomorphic VT patients had multiple episodes. The average time to first shock, 2 years, ranging from 3 days to 6 years. And all of these ICDs were placed for primary prevention. But what is interesting is this clustering. In 3 of the patients, there was a clustering of episodes, 7 episodes over 44 minutes, 4 episodes over 5 minutes, 25 episodes over 2 hours. And in all of them, the initiating rhythm was either a sinus tachycardia or atrial fibrillation, at least not in all, but in 5 of the 9 patients and 43 out of 51 episodes. So this is a fascinating condition. People go for years, no problems, and then suddenly several episodes in 44 hours, several episodes over a couple of days, and then they go again 5, 8, 9, 10 years without an episode. We simply don't understand it. In heart failure with systolic dysfunction, it's very different. Once you get device discharges, that predicts further device discharges in the near future. Now, the substrates in hypertrophic cardiomyopathy are this: fibrosis, scar, myocardial disarray, independent coronary disease is a risk factor, autonomic instability. Clearly, that woman in the middle of the afternoon with the sinus tachycardia has sympathetic overactivity. Outflow tract obstruction and a gradient, I think, is a precipitator of sudden death. And then there's the question of certain isolated myofilament mutations. The clinical correlates are non-sustained VT, shown on the left, a severe LVH, shown down here, abnormal exercise blood pressure response, which is probably an autonomic response to obstruction, a family history of sudden cardiac death, and unexplained syncope. Now, if you take patients who have none of the risk factors, and this is a recent series from Spirito in Italy, 600 odd patients, no or mild symptoms, and no risk factors for sudden death, other than that they have hypertrophic cardiomyopathy, you'll see that there is, in fact, a slight increase in the risk of sudden cardiac death. Over 10 years, it's 5.9%. So patients with hypertrophic cardiomyopathy are all at increased risk of sudden death, but it is low in the absence of risk factors. Let me come back here. And if you look at the mean age of death, with sudden cardiac death, it's 46. With heart failure and stroke, it's much older. So here's the dilemma. Our methods of risk stratification are imprecise. They have a low positive predictive value. If you put in 100 defibrillators, only about 15 will ever get a discharge. And then there's heterogeneity within each risk factor. And by that I mean, let's take positive family history as a risk factor. What about if the positive family history is one uncle, or one parent, or 2 siblings? And we have no data on the heterogeneity. I think it's worse to have had 2 siblings die than one uncle, but we really don't know the effect of that on sudden cardiac death. And then the therapy, the only therapy that works is the ICD. Amiodarone does not prevent sudden death in HOCM. And the problem with the ICD, here are three, I lost my mouse. Here are three studies that have been published. Let me see if I can find the mouse back here again. Doesn't matter. There are three studies that have been published, including Lynn, which is our own group at Mayo, and they've all shown the complications of the ICD in patients with hypertrophic cardiomyopathy. 23% inappropriate shocks. Infection treble the normal rate because these are young, active people. Lead problems, 6.7%. Usually we quote 2%. And then the psychological trauma of putting in an ICD in a young patient, age 20, 25. It's not a trivial procedure. So this is the dilemma. We don't have good methods of risk stratification. We have a good therapy in that it is effective, but there are considerable complications tied up with hypertrophic cardiomyopathy, the ICD and HOCM. But it works. So this is an amazing slide from the Hypertrophic Cardiomyopathy Patients Association. So this guy has had 7 successful shocks from his ICD device. And it is life-saving. It is life-saving. Apparently he still drives his Harley Davidson, which bothers me a little bit, but it is life-saving. Now, it was, in terms of mutations in the sarcomeric genes, there clearly about 40 to 50% of patients with hypertrophic cardiomyopathy have an abnormal HOCM genotype. Mutations have been found in 11 or more genes. There are at least 1,500 mutations that have been described, and the majority of them involve the sarcomeric proteins, the thin filament and the thick filament, beta-myosin heavy chain, myosin-binding protein C, and then the thin filament mutations, which are troponin T, troponin C, and troponin I. Now, this paper from Watkins and Seidman in 1992 created a great deal of attention. And they described a number of families that had mutations of the beta-myosin heavy chain gene. And they described the different prognosis. For instance, if they had this mutation, 50% of them were dead by the age of 40. If they had this mutation of the myosin heavy chain gene, 50% were dead at the age of 70. And then shown up here is the so-called Val606 MET. That is a benign mutation because this family, by and large, lived to the age of 80, except that one member there. And this member here was a 14-year-old child. Now, I don't think his mother believes that this was a benign mutation. And this is the problem. For every single association, there are exceptions that may be fatal for the individual who has that exception. Now, we, and particularly my colleague Dr. Michael Ackerman and Dr. Sarah Vendries, published a number of studies in the 2000s on the genetics of hypertrophic cardiomyopathy. And what we did, we took a different approach. We didn't take families with a high penetrance of the disease. We took a series of 400 outpatients, consecutive outpatients, and asked the question, how often did we see these mutations? Well, we found them in less than 50% of patients. Not these specific mutations, but sarcomeric mutations. The specific mutations that were described in the Watkins-Seidman paper, the so-called benign and the malignant mutations, we found were very rare. We found them in only about 1 to 2% of people. They were unreliable estimates of risk. And clearly there's a lot going out there in terms of novel genetic and environmental modifiers that we don't understand. And what we really came to the conclusion was that for the individual patient, or for patients as a whole, the impact of the genetic substrate was very small. It may be profound in the individual patient who dies, but really looking for these specific mutations was of no value at all. And we also stated that there are no genetic specific phenotypes. In other words, if you know the gene that is involved, you cannot predict what the phenotype will look like. There's far too much overlap. And again, there must be novel modifiers. Now, what about the role of family history of sudden cardiac death as a risk factor? And the question is this. Many studies have shown that a positive family history is a risk factor for hypertrophic cardiomyopathy. But when we looked at the data, all of these patients in these studies had other risk factors for sudden cardiac death. So the question is family history alone without other risk factors a risk factor for sudden cardiac death? And there was nothing in the literature, but we collaborated with Dr. Marin on a series of 177 patients, 4 to 6 year follow-up, and we looked at family history of sudden cardiac death without other risk factors, because this is a terribly important point to be clarified, because if it is a risk factor, then you put an ICD into asymptomatic people because of a family history. Now, the annual risk of sudden cardiac death and hypertrophic cardiomyopathy in a previous registry was about 1% per year. And if the patients had only one risk factor, which was family history, it doubled the risk to 2% per year. And if they had one risk factor other than family history, it was about 3% per year. And if they had multiple risk factors, including family history, it was about 4% per year. So the conclusion that we made from this was that a positive family history, in the absence of other risk factors, is a risk factor for sudden cardiac death, although it is not as powerful as we thought. But we feel it provided us with a justification to place ICDs in these patients, and the guidelines have agreed in that. Now, another point to be made is sudden cardiac death in patients presenting at the age of 60 years. Now, in this series, in people over the age of 60, a significant number had 1, 2, or 3 risk factors. But if you look here, and I'll blow the slide up, if you actually look at the risk factor, the rate of embolic stroke, heart failure, and sudden cardiac death, what you can see is that in patients over the age of 60 or 70, irrespective of whether they have risk factors, the rate is very, very low. So the risk stratification for HOCM starts to fall away in its ability to predict events over the age of 60. Being older with hypertrophic cardiomyopathy is a good thing. Being 15 years of age with hypertrophic cardiomyopathy is bad. So the guidelines, which I co-chaired, are the ACC-AHA guidelines, said in patients with a prior cardiac arrest, an ICD is recommended class 1. If they have a family history of sudden death in a first-degree relative, or a wall thickness of 30, or recent unexplained syncope, an ICD is reasonable, class 2A. The only reason we didn't make it a class 1 is we have no randomized trials, and we don't in any aspect of hypertrophic cardiomyopathy. If they have non-sustained VT or an abnormal blood pressure response, if they don't have that, an ICD is not recommended. If they do, and they have other modifiers such as severe obstruction, gadolinium enhancement, and apical aneurysm, an ICD can be useful, 2A. And if this is the only risk factor and they have no other risk factors, the role of an ICD is uncertain, a 2B. Recently, the ESC guidelines were published by Perry Elliott, and their guidelines for prevention, when I say prevention of sudden cardiac death, are this. They took a number of these variables: age, family history, unexplained syncope, outflow tract gradient, left atrial diameter, and wall thickness. And what I like about this is they categorized them not just as dichotomous variables, yes, no, but as continuous variables. So wall thickness was not categorized as greater than 30 or less than 30. It was placed into this score or algorithm as a number, and they developed a HOCM risk score. And clarified patients at low risk with a 5-year risk of less than 4%, ICD in general not indicated. Intermediate risk, 4 to 6% per year, 5 years, may be considered, and high risk, if it's greater than 6%, it should be considered. And I like the idea of it, namely using continuous as well as dichotomous variables. But I think there's some real problems with introducing it. So let me give you 2 examples. This is a 30-year-old male with a maximal septal thickness of 39, age, maximal thickness, this should be 32, not 39. Left atrium mildly enlarged at 30, Outflow tract gradient present, yes. No family history, no non-sustained VT, no unexplained syncope. These are the variables in the score. And so the estimated sudden cardiac death in this patient at 5 years is 2%. This patient then would not have a defibrillator. Well, to my mind, an LV septal thickness of greater than 32 millimeters is probably the most powerful risk factor that we have. And I would definitely place a defibrillator in this patient. I think they're at high risk. What about that 48-year-old man that I presented to you where the diagnosis of HOCM was questionable? What would his score come out as? His score at 5 years, his estimated sudden cardiac death risk, just go back, was 1.5% at 5 years, very low risk. And therefore he would not have had a defibrillator. Well, you saw what happened to him, and the reason we placed it was because of sudden cardiac death, and in our guidelines, sudden cardiac death and or a positive family history and a wall thickness of greater than 30 are absolute indications for an ICD. So I don't think that we're quite at the point yet that we can develop a risk score and really feel confident about using that to place defibrillators. So I think this is somewhat of a controversy, depends on which side of the Atlantic you live. So my approach is this: risk stratification and therapeutic strategies. High-risk patients are those young, those with a positive family history of sudden death, recent syncope, wall thickness greater than 30. This, in a study done at the Mayo Clinic, if people have HOCM and associated coronary disease, they're at very high risk. Non-sustained VT, we're not sure about that. We think it's a risk factor. Exercise-induced hypotension, I've never seen it after septal myectomy, and late gadolinium enhancement still has to be evaluated further. But in those patients at high risk, the only therapeutic objective is to prevent sudden death and improve survival. And the only way you can do that is with an ICD. At intermediate risk are patients without any of these risk factors, but they're symptomatic, and the objectives are to relieve symptoms using medications, alcohol septal ablation, or surgical myectomy. And low risk are asymptomatic elderly patients, and I mentioned before, the main thing is to reassure them and make sure they don't have hypertension. What is the future of genetics in the prevention of sudden death and in HOCM? I'm optimistic in that it will help us to establish disease patterns. I mean, we're very soon, we're coming to the point where we can do genome-wide screening cheaply and effectively in every patient. Will we ever be able to risk stratify on the basis of the genetics? I don't think so. I don't think we're going to find that there is a pure genetic substrate that tells us who needs a defibrillator. I think there are other environmental factors that interact, and there are other factors such as wall thickness and et cetera that are very important. But it is going to help us to make a preclinical diagnosis for genetic counseling, for therapy, and this is the area that's fascinating. When you have the HOCM gene, if you're a genotype positive, you're born with that gene. You have hypertrophic cardiomyopathy from age 1. Some people develop the disease, the phenotype. Some people will live a normal lifespan, the majority, and some will die a sudden cardiac death. But the question is, it takes 10 or 20 years in many people, or 30 years, for the phenotype to develop. And so as Dr. Seidman is doing, trying to do in Boston, the question is, can we prevent the disease? Even if they are genetically positive, can we prevent the phenotype from ever developing with calcium blockers, statins, and other drugs? And that's the great interest in genotype determination. So let me summarize in this slide the guidelines, the final statement in the guidelines that we published on future research needs. Establishing the cause of HOCM, understanding mutation positive and negative, defining the link between the genotype and the phenotype. Very interesting. How do you manage phenotype negative relatives who have the genotype? Do you let them play competitive sport? Late gadolinium enhancement, therapies to modify the pathophysiology. We need to compare in large registries alcohol septal ablation and myectomy, and then refine risk stratification for sudden cardiac death. We are at a point right now where there's still a great deal that we need to know. So I'd like to just skip this slide in the interest of time and close with this. After 50 years of progress in hypertrophic cardiomyopathy, we now know much more about what we do not know. And this is an area that will be very vigorously investigated in the coming years. Thank you again for